normally my passion is ultrasound, but this is, as you rightly said, pan scan is also a debatable topic. But in the next 20 minutes or so, I would like to clear certain points for our budding emergency physicians so that they can take a judicious decision in what scan is to be done in trauma. So I hope you can see my slides.
Yes, sir.
Yeah, and I'm audible.
Yes, sir.
So, yeah. So let's take a case. It's always good to have a case discussion and go ahead. So you're caring for a 24-year-old male who presents with a motor vehicle accident and with abdominal pain. The speed was around 45 miles per minute. Vitals are normal, but your examination reveals that a right upper quadrant and a right lower quadrant abdominal pain is present with no peritoneal signs and a negative EFAST on the ultrasound. The rest of your secondary examination is normal, but no other tenderness or visible injuries are present. You provide fentanyl for pain control and anxiety, and you ponder on your next move. So, what is to be done next? So, what imaging is needed? That's a $1 million question in the emergency department. And there is a debate. So, does this patient require the infamous PAN scan or the whole body CT scan? Or is it just okay to do the EFAST and move ahead? Or do you want a selective CT scan? So obviously, as all of you know, tunnel of death, and those who have undergone a CT scan or a MR is still horrible. I myself came out of a MR being claustrophobic. CT is slightly better, but it was termed as a tunnel of death because it becomes claustrophobic for many patients, but it can be life-saving in many patients either. So, what is the ground reality? Studies in trauma are often protocol driven, which may include the ultrasound, the EFAST, and the whole body ultrasound for the trauma protocol. It may include chest x rays, pelvic x rays, laboratory testing after the initial history and examination. Now, this thing that history and examination is equally important in trauma, though it may be very brief or you may not get much time for it, or sometimes you may not get a proper history because, in the case of polytrauma, you may not get relatives or friends or people who accompany these patients. And unfortunately, these tests have limitations in diagnostic accuracy and sensitivity for detecting injuries which further require intervention. That's very, very important. So there are obvious limitations, and the diagnostic accuracy may not be sensitive and specific for these injuries. Now, physicians like us often rely on more advanced imaging to evaluate dangerous injuries in trauma, such as CT scan. CT is sensitive, very rapid for detecting injuries, and with more and more technology coming into picture and multiple size CTs being there, CT scan, the time for doing a scan, a whole body scan, has really come down significantly. Now, CT has been increasingly used in trauma, and a whole body CT scan is commonly used to assess for traumatic injuries. Now, what is a whole body CT scan? It is a The protocol varies depending on institute to institute, but it commonly entails the CT of the head and the C spine and a screening of the whole spine without IV contrast, and the CT of the neck, chest, abdomen, and pelvis with the IV contrast. Now, some institutes just do a plain scan, and the ED physician and the radiologist can take a joint call whether you require a contrast. And some institutes like us do a CT plane heads and screening of the spine without IV contrast, but a contrasted scan is required for the neck, chest, abdomen, and the pelvis. Now, the alternative is selective imaging, which is based on history examination and other tests like the ultrasound labs and X-rays. So, just the selective imaging, no whole body ultrasound. So, what are the pros of whole body CT scan? So, the supporters of whole body CT scan, which includes me also, argue that it allows rapid diagnosis, early treatment, while shortening the ED length of stay and the hospital length of stay also, and improving the outcomes. Now, whether mortality reduces or no, we will discuss it as my talk goes on. Now, proponents also argue that decreased patient mortality, it decreases the time to diagnosis, it decreases the time to treatment, and it is based on several observational studies. Now, what are the cons of this whole body CT scan approach in trauma? Those who advocate for selective imaging state that whole body scan may increase the radiation exposure, and the association between malignancy risk and radiation is generally accepted, But the specific of these associations are not as clear cut. Many models still assume a linear relation of radiation exposure and cancer risk. So that these are the two cons. More cons. A second consequence is increase in the incidental findings of the CT, not that what you're looking for, not that which is related to trauma, but this number approaches almost 53% of patients undergoing a whole body scan as compared to 34 to 45% for those undergoing a selective. Slightly less, may not be statistically significant, but yes, the incidental findings definitely increase on the whole body scan. Do these findings really require further evaluation? Now, it's difficult to know whether overdiagnosis is associated with increased cost, patient anxiety, and further radiation for more evaluation. So, this is also a con for the whole body CT scan. Now, 15 to 45% of abdominopelvic scans will have some incidental finding. Now, as high as 45%, okay, which is still significant. And some have imaging features diagnostic of benign disease, with low rates being in the head and neck. Higher rates for these incidental findings, as much as 45%, mostly in the abdomen. Some have potential serious morbidities, increasing incidence with increasing age. For example, you may have an incidental aortic aneurysm, abdominal aortic aneurysm, which is not ruptured or which is not related to trauma, or you may have cholelithiasis, or you may have some malignancy which is incidentally picked up. But these are incidental findings not related to trauma. Majority of the patients with incidental findings, as much as 75%, have no traumatic injury in the abdomen or pelvis. And there is a higher chance in some studies of identifying an incidental finding, 30% versus a traumatic abnormalities, which is 15%. So nearly 50% more. And these were highlighted in these two studies, which I have mentioned down below. Other cons, potential risk include also increased time for treatment for dangerous injuries and obviously increased cost because you are imaging more structures or the whole body itself. Now, what about mortality and whole body CT scans? Now, you had Salim and group in 2006 evaluated almost 600 trauma patients with significant mechanism of injury with no visible external injury, and the findings of the whole body scan changed the management in as much as 19% of patients. Unfortunately, here no comparative group was used, and the examination of the patients was not well described. So, not a very high powered study. Huebner and Wagner also in 2009 retrospectively evaluated as much as 4,600 patients with a comparison of mortality as predicted by the trauma scores. And the whole body CT scan group had as much as 25% less mortality than the predicted trauma score, and the overall mortality was similar. So no matter what the imaging strategy, the bottom line was that the overall mortality was not very different in both the both the studies. So Huebner and Wagner again in 2013 retrospectively evaluated 16,000 odd patients and 9,000 plus in the whole body CT scan group. And this whole body CT scan group had a mortality of 17.4% versus selective scanning mortality of 21%. Though this study was observational and the p-value was not significant, one up for the selective scan group. Meta-analysis by Caputo includes 7 studies with 25,000 patients with 52% undergoing a whole body scan, and the overall injury severity score was higher in the whole body scan, though the mortality was lower in the whole body scan group. Now, the bottom line here was time to diagnosis and treatment were also improved in the whole body CT scan, contrary to the cons which we know. Now, Jiang et al. In 2014 conducted a meta-analysis of 11 studies, almost 26,000 plus patients, and they found out that there's a decreased mortality and the ED length of stay in the whole body CT scan group. Now, the time difference was statistically significant there. Okay, but again, Surendra et al. In a systematic review suggested that such studies, observational studies, which are not very high powered, suffer from significant confounder and bias. And authors argue that meta analysis cannot be conducted due to issues with data and study heterogeneity. So you may have heterogeneous population of trauma patients in the meta analysis. Now, what about the bias and confounders again? These prior studies and meta-analysis are predominantly observational, not randomized, and based on trauma scoring system. The groups undergoing whole body scan and selective imaging often varied in the studies. That's why creating a risk of bias. and somehow expressed concerns of bias due to studies excluding patients who died within 30 minutes. Now, you can have those seriously ill patients who die as soon as they come to the ED, irrespective of what you do within 30 minutes and of completing the imaging. And the patients who survive the whole body CT scan may be healthier. And now this bias is known as a time immortal bias, and that may also have contributed to the bias and confounders in this group. Now, then came a pathbreaker which is called as reactive trial. Sherink and colleagues conducted this prospective multi-center randomized trial with modified intention to treat analysis in 2016, and this React to investigator also did not find any difference in 24 hours mortality. Now, the whole body scan group versus selective imaging was 8 to 6%, okay, and the p value was not significant. And the 30-day mortality, okay, or all patient mortality was equivalent. So, patients with polytrauma did not demonstrate mortality difference. Neither did the patient with traumatic bearing injury. So, how did React to make a difference? Now, they found out that 64% of patients randomized to selective imaging underwent CT of all the body regions, so essentially a whole body scan itself. And 54% of patients avoided the whole body scan, and this group received slightly less radiation overall, so slightly less radiation, approximately of 1 millisieverts. Now, what were the strengths of React 2? Though the mortality was the same, it was one of the first controlled randomized trial. It was multi-centric. There were clear criteria for performing CT scan and control group. There was allocation concealment maintained with use of computerized randomization. So all things done stepwise and uniformly. But what were the weaknesses of React 2? There were a large number of patients who were excluded post randomization. This was bad. And clinicians would have known what group the patient had been assigned to when the decision was made to exclude them. Now, this can introduce bias to the results, obviously. And the inclusion exclusion criteria were modified after 62 patients had already been enrolled. So that these were the weaknesses of React 2. Now, a difference in the baseline character with more patients in the interventional group having a ICIS score of more than 16, that was again a weakness. And on the first glance, this may appear to be a weakness, but in reality, it just may be that the whole body scans diagnose more injuries. That's why the ICIS score was more. And therefore, the patients had a higher ICIS score. Now, does this change our management? The bottom line is that React 2 is one of the best studies to date evaluating the question whether the whole body scan provides better mortality benefit. So, whole body scan can decrease time to diagnosis and also can improve decisions based on imaging in patients who are unevaluable. That's very, very important with history and examination and have multi system injuries or severe mechanisms of injury. So, these are the three subsets where you should definitely do a whole body scan, though the subgroups require further studies. So, patient number one group is those who are unevaluable on history and examination because they are so moribund that you don't get a history or you don't have an attendant or you don't have the relatives with them. They have multi-system injuries and severe mechanism of injury. So these three criteria are very, very important, and these groups will definitely go for a whole body scan in clinical day-to-day practice. However, improvement in the mortality is not suggested with the highest quality study to date. So that justifies that React 2 is still a very good trial. React 2 trial does not shift the posterior probability in favor of this life-saving technology. And alongside damage control resuscitation, which our colleague is going to talk on in the next talk, and surgery, the implementation of whole body scanning in emergency algorithms has been one of the biggest achievements in trauma care of the past decade. Okay, the pre-COVID era and of course post-COVID era also now. So this was one more recent study done in 2022, published in the Annals of Medicine and Surgery March, which say that this was a Thai group, okay, a group from Thailand, which says that PanScan facilitates timely detection of significant unexpected organ injuries, especially skull base, occurred pneumothoraxes, small bowel, and the retroperitoneum specifically. And it also helps to prioritize management and increase the diagnostic confidence of trauma surgeons, leading to better outcomes without any delay. Now, all these words are very, very important. It helps to prioritize management It increases the diagnostic confidence of trauma surgeons and obviously leads to better outcomes without delay. Okay. In which subgroup the whole body scan helped in this study? Skull base injuries, occult pneumothoraxes, which were not picked up on the ultrasound protocol or which may have been missed on the ultrasound protocol, small bowel injuries, which are routinely missed on the ultrasound protocol, and the retroperitoneum also, which is again not visible on the ultrasound. So these are specifically regions where a whole body scan is definitely useful. Now, what are the advantages of the PAN scan as described by this study? PAN scan facilitates timely detection of significant unexpected organ injuries. Contrast-induced nephropathy from the PAN scan surprisingly is lower than that in the CT scan, selective scan accumulated on the same admission because it's a faster scan, okay, and the contrast use may be less in PAN scans. So, what is the classical time for scanning with institutional protocols for the whole body CT scan? The actual time taken for scanning, okay, not the downtime for the scans, but from shifting the patient from the ED to the scanner and getting the report, it is as low as 8 to 6 minutes. And with a higher slice scans and a more technologically more advanced scan, it may be still less, okay. So if you see, we compared the pan scan versus the selective imaging. The pan scan was really fast. Okay, when you wheel the patient in the scanner on the table, the scan can take just 2.5 minutes or 3 minutes, as low as 2.5 to 3 minutes. Now, where should be the scanner? Obviously, it should be located close to the emergency department or even in the trauma room, ideally within 50 meters from the emergency department. So most of good emergency departments, the scanner is just besides the emergency department. What about the radiation risk? The issue of radiation is still quite important. However, iterative scans as well as split bolus protocols can nowadays reduce the radiation risk significantly. And as technology is progressing, the radiation dose with whole body scanners is coming down significantly. So it can be as low as 8 millisieverts and can be achieved with the above technology. So what about the other cons? So, how do you reduce the radiation dose? So, radiologists should use the lowest dose protocols that yield diagnostic quality imaging. So, with the newer CT technology, repeat unnecessary repeat scan studies. Okay, that is very important. And non-radiation imaging techniques were appropriate. For example, the whole body ultrasound trauma protocol, which is still robust, but you may miss out on certain things, which I said, the skull base, occult pneumothoraxes, retroperitoneum, small bowel, those can be missed by the ultrasound. Now, institutionally track the radiation doses and, of course, campaigns to reduce the radiation hazard. Now, this is an example of iterative scan technology. Most of our new scanners have iterative technology, higher slices, okay, lesser radiation, and faster time, of course. So let's come to the ultrasound trauma whole body protocol. How does it help over a CT scan? Not exactly this topic, but obviously no radiation. It's bedside. It's repetitive. It's cheap. Imaging choice in pregnancy guides life-saving bedside procedures also. So you can do USG guided procedures like drainage of the pneumothorax or a hemothorax, or putting in a pigtail catheter or draining the pericardial effusion, so on and so forth. And the paradigm shift in ultrasound is also moving away from the compartmentalization. You have to follow the whole body ultrasound approach, not single organ, but a whole body ultrasound approach. And that's where the trauma ultrasound protocols come into picture. This was first propagated by Dr. Darian Lichtenstein, who is the father of point of care ultrasound. And it requires proper amalgamation of ultrasound of vital organs depending on the clinical scenario. Now, so what is the take home message from this talk? There are protocols determining the need for whole body ultrasound in trauma. Most of these protocols take into account the mechanism of injury, the patient injury, the number of patient injuries, the hemodynamic status, and other studies such as labs and the fast scans, okay, fast scans, ultrasound protocols, with recommendation to obtain the whole body scan in patients with abnormal mental status, hemodynamic instability, and suspicion of critical injury. So these are places where you will definitely ask for a whole body CT scan. Now, ultimately, the ED physician should go through the trauma ABCD. That's very, very important. Conduct a history and examination. That is not a substitute for your investigations, be it be any imaging, whether it is ultrasound, X-ray, or It may be a whole body scan. And ultrasound also should be a component of this examination. Patients with concern for severe polytrauma or those who are not clinically evaluable may benefit from a whole body scan. At this point, in patients who are evaluable with no evidence of polytrauma, selective imaging based on the history is recommended. So, this is the place where you will do a selective imaging rather than a whole body scan. Those patients who are evaluable with no evidence of polytrauma, there you can opt for the selective imaging. So just summarizing, potentially earlier and integrated with resuscitation, that should be the whole body scan. It's now the mainstay in blunt abdominal trauma, and outcomes are not very well established. But high speed CT, dual energy CT, iterative technology is preferred. A trend towards endovascular therapy for selected subgroup of patients who require intervention, especially for bleeding. And you need to tame the information explosion with the detection of more subtle diseases and incidental findings, which we discussed in this talk. And of course, increasing concerns about radiation exposure, but you still have options to reduce that, which I have discussed. And there's still potential to improve the appropriateness and reduce the radiation dose further. So uh, if there are any questions, I can answer that. But before that, discovery can be a nuisance. So any new technology and discovery can be a nuisance, but replication is science. But implementation is what which matters. So I'm pretty sure that I made some points which will help all our budding emergency physicians to use a whole body scan, okay, judiciously and wherever it is required in a trauma setup. Thank you.